Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy you chose to spend this hour with us, and we are excited about continuing our discussion of cutting edge technology. And without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
Good afternoon, everyone. Welcome back. And we have an exciting program today. I just returned a few days ago from a convention of the National Medical Association, a gathering of over several thousand Black physicians from all over the world. And among the things that was discussed there was the fact that artificial intelligence or machine learning is very impactful to your medical health. And I was excited to hear about the advances of a company that I've been involved with for the past 5 years and related to Black Health Trust. You'll recall some years ago, we formed a relationship with something called Second Opinion. And that company has morphed into something called Dr. Dre. We have with us today as a speaker, Dr. Ajay Ananda. He happens to be a neurosurgeon, was formerly the chief of pediatric neurosurgery at Kaiser Sunset. He's a pediatric neurosurgeon. He's at another Kaiser in Woodland Hills. He specializes in deep neurostimulation and is a very well recognized expert in the field. He went to Brown University as an undergraduate student. He went to University of Alabama. He went to San Diego University, and he's a renowned expert in deep neurostimulation as well as spine surgery. And he is the director of medical affairs, the senior medical officer for the company. And I welcome him to talk to us about what Dre and Hey Dre can do for our patients. And it's very important that this company is culturally and clinically competent. And it's very important that we embark on a way where we know that the literature as the software reviews has Black people in mind. Dr. Ananda, please talk.
Thanks a lot, Dr. Maxey. I really appreciate the very, very kind, flattering introduction. It's a pleasure to be on with you again. I think this is over the last several years my third cameo on this program, and I really appreciate the kind invite. Today, I am speaking on behalf of Hey Dre. It's an artificial intelligence that everybody can use. It's free for consumers. You can go to it by heydre.com. Is it possible for me? Can I share my screen? Is that a possibility? No.
Yes.
Okie dokie. So I'm going to screen share here, and I'll start with this. So right off the bat, this is a QR code that somebody can take. You can take a picture of this. It'll take you to the heydre.com website, Heydre, HEYDRAI.com, and it opens up. You register and you start out with. It becomes like a chat box, very similar to ChatGPT. In fact, I get asked the questions all the time, like, how is this different from ChatGPT or Open Evidence? And most of you are probably very familiar with artificial intelligence and use it in your day-to-day lives, whether it's with ChatGPT helping you plan a trip, or Gemini, or Meta, or Grok. And many of you use Open Evidence. Open Evidence, if you don't use it already, it's a free app you can download. If you're a physician, you put in your MPI number and gives you access. And it's basically a tool, an AI tool to look at the database of PubMed. and you can ask it questions, very, very specific questions or very generic questions, and it'll give you the literature inside it from a PubMed search. ChatGPT does a very similar thing. It searches literature and condenses information. However, it uses a different search database, the OpenAI database, that's a little different from Open Evidence and PubMed. And what Hey Dre does, what Hey Dre gives access to, there are two big refinements over both ChatGPT or Open Evidence. One, it's a much larger database it searches. It searches everything that ChatGPT does and Open Evidence, and then the entirety of the web. The secondary thing that Hey Dre does as a tool that's very good for the non-physician medical consumer, so just your patients out there, is that it's an interaction where if you ask it a question, specifically if I'm a consumer and I have a problem with my knee, and I ask Hey Dre a question, it will not only give it the answer, but it'll generate follow-up questions as if you're having a conversation with your own doctor. And it's done this as a language model by programmed several million interactions of patient-physician, patient-nurse interactions. And so it has a specific cadence, like you're talking to not just a person, but a person with an expertise in the problem that you have. And because of that, this is where it's the real nuance, where it's different from ChatGPT for the unsophisticated medical consumer. As a physician, I can go onto ChatGPT and ask a very specific list of questions based on my knowledge of differential diagnosis, what tests would be most helpful in steering the diagnosis I'm looking for, and questions over to what the treatment subtypes could be. But if you're an unsophisticated medical consumer, just a general layperson, you may not know the right questions to ask. You've probably heard the old saying, garbage in, garbage out. So using a tool like the internet or a large database or even an AI, you're going to be limited by your own knowledge of the subject matter. And so that's where the interaction with Hey Dre, not only is it a bigger search capacity, search database, the way you interact it is very unique. And that is here to give the very similar feelings if you're talking to a person, a doctor, your own personal physician, and by teasing out the specific questions about your health, about your medical record, it can give you the most optimized and accurate response. So I'm going to now, so this is just a QR code to help you get onto the Hey Dre website if for those you need help, but it's just heydre.com, very simple. I'm going to share just a few slides as I to kind of like keep me focused, so to speak. I'm just going to change the viewing format here. Can you, Dr. Max, are you seeing this PowerPoint slide?
No, I still see the image you had before.
Okay, hold on. I'm going to see if I can. What about now? Are you seeing the?
No, I still see the QR code.
Oh, I'm so sorry. Hold on a second. Apologize. Hold on one second. Okay, I'm going to try something else. How about now?
Yes,
There we
now,
go.
this is
Okay, sorry about the little technical challenge I was having. And now I'm going to change the view here. Hold on. Second.
Simon, can you help him?
Okay. It's fine. This is totally fine. I'll do it in this form. So the name of the parent company, Hey Dre, is a product The parent company is Dre Health. And I just want to talk about, what I'll be talking about. This is a very quick 10-minute or less conversation. And you can ask me anything if anybody has any questions. Feel free to interrupt me, or we can wait until the end. But I'm just going to talk about some of the problems in healthcare from the perspective of a consumer, and then what Hey Dre can do to help patients and how we can support physicians. Okay, very quickly. And so some of the realities of being a patient, and especially in as being Black physicians in the Black community, African American community in America, these are real. These same problems that affect everybody, I think, in some ways are exaggerated in an underserved population. First is where you live determines your medical access, and this is really true. Where somebody's access and the quality and quantity of care they can get living in Los Angeles or DC or Chicago is very different from where my in-laws are from, rural Alabama. The access they have, the providers they can see, it's very different. Rural Alabama compared to Los Angeles, where I live, and where my wife lives, compared to where my wife's parents live. Second, who you know and what you know really determines how the care you get. And we see this firsthand in how in every layer of society, obviously bias comes into play. But even recently among African Americans, you see that pain medicines given post-operatively from a surgeon to African American patients in America is different than how they give pain to the non-African American general population. So who you are, what you know, really determines the kind of care you get, where you get it, and how you get it. And then finally, where are your medical records? Who has them? Who can see them? And why don't you have them? You, the patient. So as we know, we can go get our labs at one institution, our x-rays at another, MRIs at another. We can have our children born at another, and then go see our doctors in an outpatient building. And all these different aspects of your healthcare are siloed, and oftentimes they don't interact with one another. So this creates this big jigsaw puzzle of how fragmented your medical records are. So in the pictures, like you get your medicines in one place, you go to hospital at a different place, your imaging in another place, then you actually go see a doctor someplace else. And the doctor may not have access to where you got your labs, where you got your imaging, what medicines you've been on. And so this really creates suboptimal care for both. It makes the providing of care difficult for the physician, and the recipient of care, just the product is much worse. And so this is a very common scenario. You see a doctor for the first time, maybe it's a specialist, but the doctor doesn't have tests that are very germane to what they're seeing you for. This wastes time, this wastes energy, leads to a lot of frustration, and ultimately there are tests that are repeated, tests that can be that can be costly and even threatening with a risk profile, or you don't get the full picture. So you have inadequate treatment or mistreatment. So this is a big ongoing problem, is who owns your records? Ultimately, by law, by HIPAA, by law, the patient is the owner of the records. But because of technological constraints, you're rarely the curator of your own records. The hospital keeps records of you, your medical office keeps records of you, your pharmacy keeps records of you. When you go get your MRIs of your back or head or CT, they keep those records, and then they share them on your request to to the providers you wish them to be shared with. However, you as a patient rarely ever get them, or it's very difficult to have access of it. And what Hey Dre is offering is in your phone or any anything that's connected to the internet, a patient can upload all of their images, all their information, lab tests, doctor reports, hospital, immunization results, everything, and not just have everything stored, but have a doctor in your pocket, have an algorithm, a website that the patient can use as a tool to interact with, to have questions, to answer questions, to help them through medical decision-making. And as physicians, you might at first say, well, could this provide bad care? Could this impede my ability to care for my patient? And actually quite the opposite. The more knowledgeable your patient is, the higher likelihood of them to have better care. The more sophisticated the medical consumer they are, the more empowered they are with their own health, the better decisions they can make, the easier it is for them to the easier it is for you to provide health care for them, the easier for you to have preventative health care as well. And so this is just a quick, looking at the benefits of DRE, specifically, you look at efficiency, you have fewer repeated tests, more accurate tests, the right test for the right circumstance. And then the person is at the center of this. The person is empowered as they can control in a way that they haven't been previously been able to, be the curator of their own medical records and make the most educated decisions that they possibly can. And so this is the idea, is having not just a doctor in your pocket, but your entire medical history, your medical life, whether you've moved from one city to another, had kids in one hospital, then another hospital, just the entire medical profile in a single place that you can share with people you wish to share with, as well as having this artificial intelligence able to like shepherd you through different decision makings. The final slide is what it can do for the provider is a much increased efficiency and improved outcomes. And you have a way to interact with your patients on a much deeper level, as what's currently available is a free for everyone consumer product, heydre.com. Think of it as like a ChatGPT, but specifically designed to shepherd someone through their health journey. What will be available in the next couple of weeks will be what's called DRE Pro for physicians. It'll be similar to the patient side, but you can view all your own patients that they've given you access to. You can schedule. You can have it can generate differential diagnosis with cited resource material, and ultimately, the next month, 2 months down the road, as our software gets a little bit more developed, it can interact with your own EMR. If you're using Epic, if you're using some other off-the-shelf EMR, this will write SOAT notes, have voice-to-text dictation. It can interact with your pharmacy. It's really like a one-stop back office, front office for the provider, while having a very streamlined interaction for the patient. So that's a lot to cover in, I think 8 minutes. But just to wet your whistle, just to give you a little appetizer of what's coming, what's currently available, and how this can really, our hope is this will really revolutionize healthcare in a good way. It help patients be able to take better care of themselves. And now I'm open to questions.
Thank you very much, Dr. Ananda. This is a very interesting prospect. I especially like the vault. I get patients every day. They come in, they have a little bag of medicine. I say, "Where are your records?" They bring me a CD and have an image that I probably can't read on my computer, but I have no idea where they got the MRIs, where they got the imaging done, and records of their hospitalization. So this could be very helpful. I did try it last night on a patient that I've been asked to consult on, who's admitted to a hospital, had kidney failure and what we call rhabdomyolysis. And I was able to put her results in. It came out with a good differential diagnosis, which allowed me to properly advise her and the physicians taking care of her in the hospital. So that's very good. So the question I have to you, a lot of people know that a lot of the articles from PubMed and other places take into account research that was not done on African Americans. How does HeyDRE address that now and in the future?
So the same limitations, like if there's research that's not taking into account the specific comorbidities and, just our own differences, African Americans versus white Americans versus Asian Americans, HeyDRE is not going to add or manufacture literature, but it's a very powerful tool that'll be free of any bias. Right. So the limitations of, if you look at, prostate cancer in African Americans and what their, response to treatments. If you look, for example, because, I take care of people with prostate mets to the brain. if you look at the African American population, their survival 5-year outcome with prostate cancer is way worse. So we don't know if it's because their chemotherapy they respond differently to chemotherapy or radiation, or it's really because they're getting diagnosed at a later stage. Maybe they're not getting their PSAs checked, or not good. So the limitations in the literature are the limitations in the literature, but to be able to search the literature and give you an answer without free of bias. So the idea of why the presumptive idea why African Americans in America get less pain control, even for the same post-operative operation, is that it's the bias in the physician writing it. It's like, oh, they're maybe the patient's very stoic, and because they're not showing pain, it's the surgeon's not offering pain medicine, or the surgeon actually has a bias saying that, oh, I don't want to have this person. They have some, some prejudicial bias saying, oh, I don't want to get this person might be more likely to get hooked on narcotics, so I'm not going to give them narcotics after what should be a very painful surgery that they would give a white person a high narcotic dose. That's an example of bias. That's not a result of any like true dispassionate search of the literature. That's their own bias. And the beautiful thing about Heydrey, or frankly other AI, algorithmic sources, this is programmed without any bias. And so the results that you would get are based on the information you put in. So if you say, I'm looking after an African American male, they will search for things that are most germane. That kind of adds an added filtration for the database search, but it won't add any bias to it, if that makes sense.
Thank you. That's Barbara Neighbors-Stevens.
You're on mute, Dr. Barber.
Over time, we all recall how, or heard how, physicians reacted to their patients coming in with information from Dr. Google. Why do you think, or how do you think their reaction will be different with this?
Yeah, so I think the real problem with Dr. Google is that, for example, I've been a practicing neurosurgeon for 25 years post residency, and the questions that a patient will ask Google, the answers they give won't be germane to that patient. So, for example, somebody comes in with bad back pain, and Dr. Google says they could do fine with chiropractic, but their back pain is because they have a tumor in their spine, or they have a what's called a spondylolisthesis, a real mechanical instability that needs instrumentation. It's not that Google has given them a wrong answer that's going to make their care more difficult or it's that they've asked a question to the best of their knowledge, right? The thing with Heydrey is you come in, I have back pain. And then they'll ask, well, have you had tests? Do you take any medicines? Can you walk? Is it worse when you sit? Is it worse when you stand? It'll be like a physician, that type of inquiry. And that type of inquiry will narrow down their problem to a point where the answer they give, the instructions that they tell them, the differential that will be much more likely to line up with their actual problem compared to just a patient saying, my back hurts, or I have a headache, and asking Google, and Google saying, oh, you have a brain tumor, or my head hurts, or my ears are ringing. You have Meniere's disease, without having any capacity for that interaction of saying, well, is your balance okay? Have you been eating okay? Do you have any signs of double vision? These are the questions that can kind of act as an extra filter that a Dr. Google never would have. And that's why, so when you see the patient, they may have questions from Heydrey, but the hope is that's going to make your interaction with the patient much more efficient. And so that you don't have to explain why you should get a CT myelogram. They already know. Or you don't have to explain why they have to collect urine for 24 hours. They may already know. And in general, a more prepared patient is an easier to take care of patient. The problem that you talk about is a patient that's kind of has been led down the wrong primrose path, and now you have to try to like take them back and spend a lot of time explaining, well, that's actually for a different patient population. This is for a different patient population. And so I actually think that's a great example. That's the power of not just Hey Dre, but AI as a tool over just a large search engine, which is what Google is.
Well, thank you so much. Is Dr. Walks on?
I am on. Thank you again, Dr. Ananda, for being with us and sharing with us. My question kind of goes back to Dr. Maxey's earlier point about the research not being done specific to certain populations, and your comment about kind of what goes in, garbage out. How do you? I don't expect this to have an easy answer. And if you do, yay, great. but because there is bias in the research, because there's bias already documented in our healthcare systems and in our literature, how then do you get, what is Hey Dre doing, and what are you doing with it specifically to combat that? Because as we continue down this path of research not by us, not for us, then the literature from which all of AI is pulling continues to be not by us and not for us. So what are you doing specifically, if you can, to combat that?
Really good question. And this, so forget for a second even the biases in the African American community. If you look at throughout current day things like vaccinations, and there are a lot of things in the medical community that, for a lot of reasons, political reasons, reasons of bias, have, we'll say, non-consensus. Okay. And so it's very obvious, okay, if I have a knife wound to my brachial plexus, probably that penetrating trauma that needs to be removed, and then the anatomy of the brachial plexus is what it is. And it should be repaired, yada, yada, yada. But there are things that, okay, if you're older than 65 and you have hypertension, should you get these constellation of vaccines? Probably. There's a lot of consensus over that. There are certain things where when part of the interesting algorithm, and I'm not a tech guy, but I was having a conversation with our CTO earlier about what about the circumstances, and you bring up an option, one of them in the case of like very specific, African American outcomes, African American treatments, diagnostics, whether it's chemotherapy treatments or surgical treatments, what is different for a specific population? We can use African Americans as a specific example of that, but that can be the case for a lot of things where there's not exact literature that has a consensus. And so part of the algorithm of Hey Dre is that we look through PubMed, OpenAI, all the different data sources, and we look for things that'll have what's called 90% consensus, not where there's confirmation to a high degree. Now, there are certain things where we can't achieve that for whatever reason. And so if you have a very specific issue, you can't achieve that. So for what we are doing as a company, we're just trying to provide as good quality as we can. When you can't get 90% consensus confirmation, those searches will get flagged, and we'll have a quality, just like any service oriented, whether it's a department, a hospital, anything in healthcare, you always have these what we call QM, quality management, quality assurance initiatives. So for us, since we're not actually like doing surgery and we're not getting post-op infections, where do we get our bad outcomes, if you will, to go investigate these QM issues? For us, when we have non-consensus, when we have like this our bar is 90% confirmation. If it's below that, those get flagged, And then those get reviewed. And so we can have, so a lot of these, maybe in like, African American searches, for example, where the literature is more spotty, you're never going to get as good the same quality of evidence where you're going to get, so when you have more conflicting evidence, then that quality, that confirmation number is going to go down. Once it drops down below 90%, that will get flagged internally where we'll have our own panel review it and try to improve. If there's something that we can do to either add filters to the search, expand the search in some other way, but that'll be our own way of our QM, our self-improvement is for specifically that. So again, that doesn't address that solely or entirely, but you bring up a good question, a question that I think as the medical community has tried over the last, since civil rights really to address, and it hasn't addressed it entirely. But as a company, there are other threats beyond racial discrimination is like, economic discrimination. And there are political threats where there's a lot of information on the internet. There's a lot of misinformation on the internet. And so that's something that we have to protect against for all of our blinded of ethnicity for all our clients, all the consumers of the information. And so one of our current way of looking at this, when something has a non 90% confirmation or consensus, those things get flagged and they get reviewed by an expert panel of physicians. And that's kind of like the exact mechanics of how that review takes place. It's not fully been worked out. And it's something that I would love to work with Dr. Maxey and colleagues of yours to see how we can streamline it. But that's a very good point. And that's a problem not fully solved, but we're attempting to solve.
No. And if I can just have a quick follow-up, if I'm able to do a quick follow-up. This is one of those issues that I'm glad to know that you had a response and that you are flagging and looking. Because other AI systems have been noted to sort of make up stuff when they don't when they don't have a good answer or have the right answer and then later admit, yes, I made that up. With Hey Dre, if something has that 85% and you get the flag, does the inquiring entity also know, hey, we're only at 85% confidence or we're only at 70% confidence?
Right. So that's a great point. And we haven't, so currently in the current system, no. Although if it's below that 90%, again, everything is couched by this we recommend, seeking, this isn't a substitute to seeking a physician. And then it'll provide names of specialties and, like not just like, oh, based on your query, you would be best suited with a dermatologist or a rheumatologist. Then they can provide, if further queried, names of specific subspecialists. But there's always the bias, for the provider, for the user, which is the consumer. In our current iteration, we haven't set it up to disclose, okay, you're at this, you're at this. And that's a very good point. Again, this is kind of going to be an iterative process and how we can, provide the most useful product. And, we've kind of toyed with that idea. And also the idea of kind of listing the, source material and, providing the source material. And that'll be certainly available for the physician side of it. For the layperson, for the user, we want to make it a useful and informative experience, but not be kind of like overwhelming at the same point. So how to kind of like thread that needle, I'm still not fully, it's not, again, I think version 2 will likely be different from version 1, and probably like that'll be very different from version 3, frankly.
No, thank you. Is Dr. Hines on, Dr. Walks?
Dr. Hines is not on, but Dr. Lawson has his hand up and Dr. Coombs has a question as well.
Okay.
And we have some good questions in the chat.
Okay, let's go with Dr. Lawson first.
Okay, I guess you've been asked this a million times, but there's the user problem, AI, in terms of being able to be pleasing to the patient. And that is that providing answers that are more, that may not distress the patient. The patient, for instance, if you lead to results, saying you can get this treatment, but the chance of surviving is like 0.01%. So should you get it? And the other issue is the value issue. If you look at different treatments that's available for attentional deficit, um, should the person be getting stimulants if they have a history of drug abuse? And if that's the case, then what do you do?
So I think these are really excellent questions, and and what you're touching on is really the art of being a physician, right? So I see patients all the time with diagnosed for the first time. They haven't been biopsied, but their brain images look. They come to the ER with a seizure. You see them, and based on the age and the location and the morphology of the MRI, it looks like it's going to be a glioblastoma. Well, glioblastoma has a 90% mortality rate at 6 months, right? And so how to tell them that and what to say, these are like very nuanced thing that, like, if you take 100 board certified neurosurgeons, they're going to treat this very differently. So the interaction with the patient, with the agentic AI, with the chat box of Hey Dre, is not going to be as masterful as dealing with a person. It's just going to be it's going to be a dispassionate source of information. And so like going down the example I gave is like, say you may be logging on for a loved one. Oh, my father had to go to the emergency room with a seizure. Now they said he has a mass in this area of his brain. What could it be? Then Hey Dre is going to give it it's going to describe. It's going to describe what it could be, and then ask follow-up questions. Does he have a primary cancer? And then talk about is it a primary tumor versus secondary, metastatic tumor, and what the differences in treatment/outcomes are. But it won't be able to hold someone's hand and shepherd them through the journey. I mean, it's gonna hopefully make the next interaction with their physician much more high value. Because they'll know, maybe, like, are there genetic tests that can be tested? Maybe they'll know that okay, radiation and chemo can extend my life 1 month. But what about the risks of surgery if my quality of life goes down? It makes the interaction, it's not going to replace getting care by a physician, but it's going to make the patient more informed. And a lot of the fears and anxieties of even seeking treatment, sometimes, again, what we're talking about is the most serious, right? Unstable angina or some sort of terminal cancer. But the vast majority of healthcare questions, the answer is much less serious and much more solvable. But from the patient's perspective, there's a great barrier to ask a physician or to the fear of treatment, the fear of testing. And so hopefully those walls can be lowered a little bit. But you're right. The realities of taking care of people with real serious illnesses and looking at the end of their lives it's really hard on a physician and a provider. It's terrible for the family. But on the flip side, for the computer, for the AI, it's a dispassionate source of information. And so in some ways that's almost comforting. And I'll give you the example of, so I'm 53, when I tried to buy airline tickets or, try to get a dinner reservation, I want to talk to a person. That's much more comforting. It's yeah, I'm going to come with a party of 5 at this time. But if you look at my adult children, when they go, the idea of calling a restaurant, making a reservation is like an anathema to it. They just do everything online. They like not interacting with a person when they want to have some service provided. Whereas I find that still, I would much rather talk to an agent, American Airlines, and say, look, I changed my flight. Is it okay? Can I bring my, where they go through the same, journey without having a single human interaction. And so it's just, so part of it is kind of like you and our ideas of how information should be given. I think it'll be very different for the generation beneath us, and even more so for the generations to come.
Thank you. Dr. Barbara Davis, who else has their hand up?
Dr. Combs, and then we have some people in the chat.
Okay. Let's go, Dr. Coombs.
Thank you very much. I do enjoy this. One of the questions I have for everyone is, once AI is using the algorithms and it gets to the point where it's actually going to translate data in terms of what looks to be close to its discrimination, has done a great job, and then you get to the calibration period. So what I'm concerned about is the gap that exists with what appears in the literature and the next leap of having these expert and advisory panels do not understand that the predicted risk for something does not correlate with the observed risk. And so, for instance, having served on MedPAC, there were a few people who were really, really vocal about certain tests not being paid for by the government, almost like today, such that there were several that said the federal government, Medicare, should not pay for PSAs. And the other one was Medicare should not pay for women who have hysterectomies so they're over to 65 years of age, regardless of the reason why they had the hysterectomy. And the problem we're having now is that there's such a knowledge deficit with people who are making these major decisions about the next step of healthcare, whether it is approval, for certain procedures, and relying on AI as a screening tool for whatever it is. And I know everyone saw the article that actually saw at the end of quote unquote mental health counseling. The person fictitiously asked, "Should I commit suicide?" And AI responded, "I think so." And so, how do we get to the payers, which are really invoking some of these principles, and some of you who are, this is near and dear to your works place, but that's the problem I have, that they're making policies, reimbursement, things along the line of affecting providers in ways in which it ultimately trickles down to the patients without the healthcare literacy that should accompany it on the IT side, on the AI side. But most of your rank and file physicians, they're not in the AI. And if an insurance company comes along and says, I want to do such and such thing because AI tells us that we've gotten the sensitivity and specificity down to an art. We got the discrimination, and they haven't done that last step of the calibration. Then you have major problems, I think, with people just taking data and throwing it at a board and saying, I got to couch this data so that we save money.
Dr. Coombs, just remind us of your job when you were in New England.
Oh, I think we talked about this before. I was president of the Medical Society, Mass Medical Society, which is publisher of the New England Journal.
So a really awesome question. And what that question talks about the other side of AI, right? So I'm talking about it from the perspective of the consumer using it to try to kind of shepherd their way to whatever their health and wellness. You're talking about it, and your question, if I'm going to just paraphrase, is like, there's going to be a tension because the insurance provider is using AI to gather all this information about all the different patients and then collate that with all the data they have, like, okay, what's the most effective way of screening prostate cancer? Is it PSAs? Is that effectiveness go away after age 75? Whatever it might be, is it? And so like they can save money on these tests, save money on these therapeutics. And so obviously they're looking to minimize expense while trying to with some maximum integrating some maximum of efficiency or optimal health metrics, whatever that might be. And so those are somewhat arbitrary. And so what you're describing is there's a tension between what the insurance wants and what the doctor's in the middle, and what the patient wants. The patient wants to get better. The insurance wants the patient to cost the least to insure. So, right, but that tension exists now, right? That tension exists now, and AI is just a different way that the two sides are going to wage war. And so the insurance is always going to have more information than the patient, right? That's the old story is pre-internet, realtors sold their house for like 20% more than their clients. A realtor selling his own house is going to make more money on his own house than their clients. Why? Because they understand the market. They know what the market is, what the buyer is, what the sellers are like. And so that arbitrage, that discrepancy in information is always going to help the person who has more information, who has more tools, who has more leverage. So your very example states the problem is that the insurance is going to have more information. They're going to have more access to the people making decisions, what gets paid for, what doesn't, right? What has leveled the playing field more than anything else? Why we tell our children, to go to college, why we tell our children to get educated, is because we know that the ultimate thing to level the playing field is knowledge, access to information. And so that's something the internet has really provided all people. And so I think in response to your question, I think Hey Dre and things like Hey Dre are the best safeguards for patients, because you're offering access to information that otherwise would be much more unilateral. And so that tension you described, this is the counterpunch. This is the counter tension to insurances being able to leverage information in a way they haven't been able to before. And so this is the one thing on the side of the patient, on the side of the physician, on the side of the consumer. I don't know if that answered your question, but that was my interpretation of your question, the answer to my interpretation of your question.
Dr. Neighbor Stevens, let's go to the chat.
Okay. The first one is from our loyal audience member, Mrs. Hall. So Mrs. Hall says that she used Ask Dre last week and went to her cardiologist, who was not aware of the application. And so she wants to know, one, she's got three questions. One, how are you getting this information out to the medical community? And is there a cost for Dre? Her second question is that how do you get around HIPAA when giving a total picture of the patient's medical history across medical facilities? Because this visit with the cardiologist the week before had also been complicated by the fact that he or she had not been able to access her records that were in another state.
Was there a third question?
Yeah, there was. What was the other one? Oh, her first one was, how is Dre bias free when the first questions asked are about demographics?
Right. So let's start with Let's start with the last first. So the reason they ask about demographics is not to provide bias, like, oh, you're Chinese, so I'm going to treat you like as a second-class citizen. It's to know if that is germane to your health. Like, as we know, certain populations have a higher risk of diabetes or high blood pressure, have certain higher risk of this treatment. So it's purely not to participate in bias. It's just an added source of information to try to provide you the most optimized answer to whatever your query is. So that's the third question. The first question, you said, okay, how do other physicians know about it? So this company, this space is new. And so, yeah, that's the task of marketing it. And, like I said, the Dre Pro version which is for physicians, isn't even out yet. It'll be out in kind of the alpha form in 2 weeks. And we're going to market to physicians. It's gonna cost physicians money to use it. The early adopters will cost less. And the idea is the physicians will get a lot of value. And so I'm not in the marketing or business side of it, but physicians who use it, they're only going to use it because it's going to make them money, right? We're in a capitalistic environment, and the hope is this is going to provide a service that's going to make physicians money, and they're going to use it. Now, the middle question that you asked, I thought is the most germane, and this really affects people every day. If you're a physician, you've not seen a patient that hasn't been affected by this. It's impossible. The fact that our information as patients is everywhere, but within the most important person, with us. the patient. So the cardiologist can't see tests from some other state. The patient doesn't have them, even though it's of her body. So do they want to take, some, especially with cardiology, a lot of tests cardiologists do are invasive and they subject a patient to risk, and you don't want to reproduce them and redo them unless you absolutely have to. And so the way you can think of the platonic version, the idealized version of Hey Dre is all your records are on a cloud that are HIPAA compliant. It's encrypted in a way that without your authorization, without your explicit authorization, no one else can look at it. Okay. No one else can say, oh, Miss Jones has this problem and we're going to, go after her because of XYZ. No, it is you, just like when you go to a doctor's office, you can sign a form. Like in the case of, you're seeing an orthopedic surgeon and you had a hip x-ray or hip MRI at, Image Center in Torrance. If you want orthopedic surgeon X to Dr. Smith to see that, you have to go to the imaging center and sign a HIPAA release form. And that says, okay, you've granted them, it's your picture, you've granted them permission to share your information with Dr. X, Dr. Smith. That same capacity, that there's laws that govern your ability to share with who you choose. That same capacity will exist through through Hey Dre. It'll just be much easier. You don't have to drive all the way to Torrance and then find somebody, go and wait. It's just that once you electronically say that I can share this segment of your medical record with Dr. X, boom, they can view it. And that's the beauty of it. You don't have to chase around. You don't have to call somebody in Idaho where you had one picture and a lab test in Providence, Rhode Island, where you had another lab. It's all curated, available, secure on the cloud.
Dr. Walks,
Hopefully that asks those three
Okay.
questions.
Dr. Walks, anything else in the chat? Dr. Neighbor Stevens?
There are other things in the chat, Dr. Neighbor Stevens.
So,
one question I
follow
had
up.
is, how does
Follow
this
up.
information? I'm sorry.
Are you doing the follow-up for Ms. Hall?
So
Yes.
I saw in the chat, it said, how does the information get shared? So if I'm patient X, I'm Miss Jones, I've loaded up my angiogram and blood test onto Hey Dre. There'll be a provider side of that they can sign on and then view it, assuming that you've given them permission. Just like now, if you go to Cedars, and get a brain scan, an MRI, and then you go to a neurologist that's not affiliated with Cedars, that's someplace in the Valley, for example, you can share them your password, not your password, your like you can share them your like login essentially to view those images or view the report of those images if that's what they want to see. It's a little bit more cumbersome, but it's possible. But at least in that circumstance, it's possible only because Cedars has like a web-based system to do that. Imagine that now accessible, not just Cedars who get their imaging at Mark Taper, patients who get their imaging at Mark Taper at Cedars, but for everyone, regardless of where you get, medical record X, imaging Y, blood test Z, it can all be collated. And I don't exactly know the code, how the Hey Dre site will pull it from that, but it has that capacity to pull the information given that you've given it authorization to from these different entities and store it.
Thank you so much. We're almost at the top of the hour. I want to ask just a few more questions, if you don't mind. How would physicians pay for this, and what's in the offering for physicians who sign up to use it early, especially from the National Medical Association? Are they going to be able to use this for free for a year?
So right now, first of all, you can use the consumer patient portal for free. Anybody can, whether you're a physician or not. The Dre Pro site will be launching in a few weeks. And when it does, the early adopters, it will be free. Then there'll be a subscription model. I'm not on the business side of it, so I'm not exactly sure what their overall costs are going to be. But the way you sign up, it'll be very similar to the open evidence where people have used it. You put in your name, you put in your NPI, so it'll authenticate that, verify that you're a physician, and then boom, you're good to go. And then there'll be, depending on, do you want it to use all the different premium aspects? I think that's will come with a cost as opposed to just using it as an information source. But it can ultimately, the full form of this, it'll interact with your schedule, it'll interact with your EMR, it will do your notes via what you can do. You can voice to text, dictate your notes, become part of your notes. And so it'll do kind of everything that your EMR does and the back office does at once. That's kind of the full form in the next 6 to 12 months. The first form will just be like an earlier version of that. And frankly, the early adopters, not only will it be free, but for the early adopters, your feedback is we're gonna be, the reason it's free for early adopters is we use early adopters. We get value out of early adopters, just like early adopters get out of us. The suggestions the users make are often the smartest ones, the most insightful. That'll direct what the full form product of this will be.
Well, I had an opportunity in the past few days to sit with a gentleman named Ellie, and he showed me a number of other uses of Hey Dre and Dr. Dre that are in the works to do. There's a Pro, there's a Hey Dre, and there's some other uses for the insurance industry, for hospitals. Can you briefly talk about that? And I also understand that the founder of the company, who you probably know very well, is also a rocket scientist, but has taken a number of companies public, one of which is stamps.com, I think. You would just want to briefly speak about those things?
That's quite a mouthful. So yeah, the application that I know the most about, I'm a physician, the application I know the most about is the thing that's designed for the patient. Being a doctor to me is like a very altruistic thing. And I just want the patient experience to be better. So there are a lot of other applications for AI in healthcare, in insurance. The prior Dr. I'm blanking on her name. The visitor that asked me the last very insightful question about insurance. Insurance will use AI for a variety of things. So we have an insurance application. There's an application for what we'll call Dre Pro for the physician provider that will do not just the help in optimizing and streamlining what tests to take, but how to store information, how to better communicate with your patients, how to schedule appointments with your patients, how to return messages efficiently for your patients. So those are the other products. Like that's just touching on it. As far as what the kind words that Dr. Maxey mentioned about the founder. So yeah, I know the founder of Hey Dre is my father, so I know him pretty well. His background is he's not a physician. He's actually an astrophysicist. He's also a lawyer, and he's a real bright guy. He has a lot of patents in so many different things. In fact, the very first e-commerce patent in America is actually issued to my father. And so one of his companies that he both founded and has taken public is stamps.com, and people can look at, can investigate, the successes of that.
Well, thank you.
So that's in a nutshell.
So Dr. Walks and Dr. Neighbor Stevens, anything else in the chat?
Nothing else.
Go ahead, Dr.
Nothing
Walks.
else in the chat. We've got Dr. Sherrod and Dr. Lawson with their hands up.
Okay, let's do those, and we'll make our statement brief because we got to close at the top of the hour, close to it. Go ahead, Dr. Sherrod and Dr. Lawson.
Oh, good afternoon. I'm just happy that today I'm seeing the real person, because I watched this last week and I had some questions that I thought I was talking to. I want to first just commend you on this amazing product that you've produced. My question is in general, is overall. We talked about AI at the ABWP, which is the Association of Black Women Physicians retreat, about a week ago. And the big question is, how do we as a culture influence the use of AI in healthcare to mitigate inequities? What rooms do we need to be in the policy making toward the use of AI in healthcare? That was the override. How do we influence this and mitigate the inequities that appear so often, especially for African Americans and
Yeah,
other
so
minority groups?
I think it's a really good question. It's very germane to so many things that, some of the challenges that face, minority groups in general.
Mm.
The real way where AI is kind of the tension we spoke of. The way AI will potentially be a negative influence in the lives of minorities is, can the information it uses be leveraged against already disenfranchised populations, right? So if your final thing is making things most cost effective, if you're trying to maximize for value and profit, that's going to have a different solution than if you're trying to maximize for wellness, right? That's just the nature of, and so in a fee for service, in a capitalistic environment, the insurances are always going to have to maximize for profit by minimizing expense. So that, the hope is that they do that with some regard to health and wellness, but that may not be true. That may not be the calculus that they follow, right? So the best way to kind of like shield yourself of that is, sure, if you were in positions of legislation, you can look at the way the policies that safeguard that are just like regulations, is like looking at the data. You look at the data to say, well, pre-adoption of AI, this was like Black vaccination rates. This is Black survival rates of these illnesses, right? This is the infant mortality. So there's certain metrics that look at duration, quantity, and quality of life, and and the whole goal as we move forward in a society, that those are colorblind, that those should not be related, like, your infant mortality if you're Chinese in America or Puerto Rican or African American, that should be the same. So these metrics. So the burden on policymakers in the world of healthcare should be to look at these metrics, the correct metrics, and see if in fact they are color blinded. Now, but that's not the way AI will help or hurt minority populations. The way AI will help minority populations, it's a tool. It's a tool that if it's only accessible by the very wealthy, then it's going to hurt minority populations. If it's free and accessible by everyone, then like any tool, it can be leveraged appropriately or not used. It's kind of like having a library card. A library card is an awesome equalizer if you know how to read, and if you can get to a library. But without that, then there's limitations. So, but the idea is, like, you're not just bringing the library to the person, you're bringing the librarian, you're bringing the translator, and so AI is such a game changer for people that would otherwise be disenfranchised, or kind of like the playing field would be very asymmetric as far as access to information. And so that's why I look at it from the side of the person. But you're right, from the side of an institution, of a country, of legislation, there's nothing special about AI. It's a matter of, what are the metrics that mean the most to you? Is it surviving different illnesses? Is it diabetes? Is it, A1C control, diabetic control, blood pressure control, because that's going to lead to less kidney failure and less strokes. These are important metrics that I think specifically germane to African American populations, where they have a higher incidence of stroke, have a higher incidence of kidney failure, likely because of, uncontrolled diseases that can be controlled, right? Diabetes can be controlled. Hypertension can be controlled. Obesity can be managed. All these things can be managed in a way that can cause superior healthcare results. So I would look at, for the question of what you look at policymakers, is people that can dispassionately look at the data. And so if our goal is to have these metrics to be colorblind, they should be the same across populations. The ways to do that like that's those are the policymakers and how to regulate policy to ensure that. But for the lay person, your best protection is information. Your best defense, your best equalizer is knowledge. And so I think of AI as a tool to make equaling that, leveling that much easier.
Dr. Lawson, you have the honor of the last question.
Yeah,
Thank you very much.
Yeah.
Dr.
You're
Lawson?
muted.
You're on mute, Dr. Lawson. Dr. Lawson, it looks
got
like
it.
now you're
Okay,
off. Go-
now very quickly, one of the uses in terms of the system that I'm using now is that it's one of the data points that's used to build in terms of psychiatry and psychology is the verbiage. And this way to using a system that takes your verbiage and expands it so that it's more likely to get the appropriate billing on it. And then we use the other direction, that is to take technical information, technical reports, and rewrite it so that the patients will understand it. And which is a real issue because many of our patients have less than a fifth grade education. So I'm just wondering your thoughts about that, and especially the opportunities for bias, and also the fact that the physician is going to have to go back and look over it and make sure that you really convey the information that you want.
No, I think this is a very good point. I think for the uneducated or less sophisticated consumer, having a way, I think that's where the real value of HeyDray is, frankly, compared to using like a traditional a Chat GPT or Gemini or Grok, is that if you're an unsophisticated consumer and you're like, my knee hurts, or I get up to pee 10 times a night. That is too wide of a question to ask an AI. You're going to get all kinds of you're going to get the weird Dr. Google results that you have like some sort of bladder sarcoma when when you definitely don't. I mean, the odds of that are less than one in a million for the pee at night. It could be so many simple things. And that's where asking, okay, how old are you? Are you African American? What other medicines are you on that could lead to the peeing at night? So it's going to synthesize information in a way, it's going to ask questions that are simple, questions that you would know the answer to. And if you don't, you say, I don't know, it'll ask a follow-up question. And that's really the power of this specific large language model that HeyDray is using. And it's like anything else. The next time you use it will be worse than when you use it a week from now. It'll be worse than when you use it 2 weeks from now. That's the nature of this algorithm of any large language model, but HeyDray specifically, it will get better and better and better, and it'll be tailored to you. It will remember the conversation it had with that patient. And so it's verbiage, its level of technical detail is going to be a reflection of the user. Does that make sense?
Thank you so much. We are so glad you were with us today. I liked your explanations. I hope you can come back and visit us sometime soon. Would you like to make a final comment?
I really appreciate the questions. I actually, always learn more from the questions than any of my content, because that's, that really, the product should be a reflection of the users, and the questions are, will guide us, and other members of our team are listening in, and this will be very helpful. So I just want to say thanks for having me, and I really appreciate the feedback and all the engagement.
Thank you so much. Dr. Ivan Walks.
Dr. Nanda, thank you so much for coming back and for talking with us. I think that every time you come back, I'm struck by two things. One is that, for a surgeon, you really talk to people very well. I remember being back in medical school, and all that bedside manner didn't go with the surgeons. So God bless you to really be able to talk to people. It's an absolutely very, very useful skill to have. And then the second thing is, I think that this conversation that we're having and this ongoing conversation about AI, I think is going to continue to be more and more important. And the reason I say that is if everybody else is doing it and you're not doing it, the only outcome is that you're left out. And so to Dr. Maxey, where he started us with, how can we be involved? How can we make sure that these diverse voices are a part of this conversation? Thank you for encouraging us to be a part of that, and come back and talk to us some more.
Well, you're very well. Thank you so much. Really, really flattering. I really appreciate the kind words.
Thank you. That's Barbara Davis Stevens.
Thank you so much for coming and again and helping us enter into this new world. As Dr. Maxey said, we were at the National Medical Association meeting last week, and there was a lot of discussion about AI. And one of the speakers, whose name I cannot recall, but I do want, in with that anonymity, give him credit for this analogy, because I think, is one of the best analogies I've heard. And I think it's a good way to organize this vast new world in ways that we can take meaningful bites. And he said to take a three-prong plug. And the positive prong is your data or information going into AI. The negative is the validation process that has to go on in the evolution of the algorithm. And that third prong is governance and ethics, which all three are running crazy at the moment, and with lots of energy and lots of unknowns. So we will be in this conversation for years to come. Thank you.
Thank you so much. And as my closing comment, I want Dr. Ananda to just give us where people can log on if they couldn't take advantage of the photograph, which I couldn't, where people can log on and get the application.
Yeah, so of course, now we don't have an app yet. It's just web-based now. So you have to go through whatever browser, just when you get onto the internet, if you just write Hey Dre, HEYDRAI.com, heydre.com, and that's differentiated from, there is something called Dr. AI, which is different. But this is Hey Dre, HEYDRAI.com. Get online. It'll take you through a very quick sign-in where it's free. You just put in your email, show that you're actually a person, and then you're live with a chatbot, and the future iterations will come out and if you sign on, you'll learn more about the Dre Pro. When the next iteration is not only the physician iteration, but also there's a premium subscription model for patients where you can ask questions for free, and ask whatever questions. It'll give you answers, and use it just like you're using any other AI chat box. It's just going to be a more easy to use and more healthcare focused chat box than Gemini or ChatGPT. But to use it as a storage for all of your pictures, where it'll go medical records, hospital charts, labs, immunizations, whatever you want. That's the subscription model, and that'll also be an application. You can store it on your phone. That's not out yet. It will be coming out in the next weeks to months. And once you sign up, they'll give you information about that.
Okay, last thing before we close is my friend Elion. Do you see him on?
Who?
I see Eli's phone.
Yeah. Can you unmute him a moment? He's been very helpful to me. He was with me at the NMA. We're introducing this to Black physicians. And he's been very friendly. And I'm assuming that Hey Dre and Dre Health is interested in having physicians who want to be on the advisory board will be welcome. Anybody can respond to me at my email that you got this invitation from. randall.maxey02@gmail.com. Have a great day. Thank
Dr. Maxey, I'm here. Sorry, I had a hard time unmuting myself. Sorry.
Hello. How are you?
I'm good. How are you?
Thank you for your interesting dialogue we had with physicians in Chicago. You have any final words you'd just like to add to Dr. Ananda?
No, I think Dr. Ananda did a great job, and no, I don't have anything to add. Not at this time. Thank you.
Okay, so you and I are going to have our kosher talk this week.
Hopefully, yes, on Wednesday. I look
Okay.
forward to it.
Okay, have a great day, everybody. Thanks for
Good luck,
joining us.
guys. Thank you so much,
Bye.
Dr. Maxey. We'll see you later.